Está bien. Sí, vamos a lavar la onda. No veo perros, sí. Sí, es porque se distraen. Se distraen, sí. La verdad es que tiene la oportunidad sería una muy buena, porque la verdad es que a mí me ayudan, ¿no? Pero no todas las personas. Así que eso para exacto, sí, sí, sí. Sí, me imagino. Si Natalia no dijo, ¿por qué lo vas a dar un curso de una taller de monitoreación? Lo que dices son estas armas. La tuya ya no vuelve a 1 de diciembre está mismo. Pero con mucho gusto la plática. Gracias. No doy charlas. Es muy frecuente una cantidad pero igual tengo ideas, sí, como que la Fabia me hace. Pero no, hay que ser porque saben los síntomas. No, más bien esto. Traigo el cenar. Pero también los demás. Tengo un laboratorio de lo que hago un poquito más en el laboratorio, voy a hablar también les importa, o sea, muchas gracias.
¿Listo? Okay, hello. Let's get started.
Guys.
Let's get started. We continue with our talks. We only have this talk today, and after the talk, we will have the movie. Remember, the movie is based on a real story, so I invite you to come and see the movie. It's going to be at 5 here. And we continue with this talk. Our guest is Violeta Gallardo Montejano. Philip is going to give a.
Hello everyone. I want to present you Doctora Violeta Gallardo. She earned her MD degree from the Universidad Autónoma de Nuevo León and completed the General Medicine Residency and an Endocrinology Fellowship at Hospital Universitario Dr. Josué Eleuterio González, where she received multiple recognitions as Best Resident and Best Fellow. She later pursued postdoctoral training at the University of Texas Health Science Center at Houston and UT Southwest Medical Center, where she became a faculty member in internal medicine and endocrinology. Her research focuses on lipid metabolism, particularly the role of HER5 in mitochondrial functions, thyrogenesis. With her work, she investigated how cells regulate fat utilization and energy expenditure, contributing to a better understanding of metabolic diseases such as obesity and type 2 diabetes. Please welcome her.
Hi, everybody. I want to thank the organizing committee for having me here. It's a really an honor. So I want to tell you a little bit about myself. I studied medicine here in Mexico, in Monterrey. And then when I finished my residency and my fellowship, since I was a kid, I always wanted to do research. I was quite curious as a children. And went to the United States for postdoctoral for 2 years. I've been there for almost 17 years. So never say you're only going to start 2 years. It's not true. So I'm going to talk about a very important issue right now, that is obesity. And one thing that if you know, it's you may have seen some. Well, here in Mexico, we don't see many commercials for drugs. In the United States, if you watch TV, half of the TV commercials are about drugs. Here in Mexico, we don't see that, fortunately. But probably you have heard about this new miraculous drug to treat obesity. And it's kind of true, but we need to be aware of the possible downsides as well as the good things that this drug. I'll try not to make this too boring. You may see some terms, and feel free to ask any question. Don't think my question is dumb, because no question is worse than ask questions. So take a look at this image, and can you guess what these images and what these different pictures have in common? I mean, some is quite clear, right? Like excessive food intake is related to obesity. So it's not only cost, but these are the new drugs for obesity, and what Lisa had to do with this. Does somebody have a clue what a Lisa then is related? Okay, I'll tell you later. It's quite interesting, this history. So the first thing that we need to know is the definition of obesity. Obesity is, we use this formula in medicine. It's called body mass index. And basically, because, I mean, if somebody is too tall, it's not the same that somebody is short. So we can really define obesity. We need to take it into account weight and height. And when somebody is overweight, that is before obesity, is a body mass index between 25 and 30. And then we divide in different classes. Class 1 between 30 and 35, class 2, 35, 40, and class C above 40. So, and these maps are actually quite recent, 2024. And these are pretty similar. These are statistics from the United States, but it's pretty similar here in Mexico. Maybe a little bit less of this here. But what is impressive, if you see here, all these states that look red, they have some up to more than 40% of people with obesity. So that's why large population. And that was in young people. This was in people between 18 and 39. When you get older, you can see how this, like most of the states, with the exception of Colorado, have body mass index, like prevalence of obesity about 45%. That's just crazy. And of course, and this is closely related with the prevalence of type 2 diabetes. So, like, for example, right now in the United States, in Texas, where the state that I live, up to 30% of the population have type 2 diabetes. So that's quite big. And why is this important? Because obesity is not just about aesthetics, but it's about complications. And it's just not only like heart complications, because we have hypertension, coronary artery disease, stroke, heart failure, and others, but also people with obesity have more risk of cancer, especially breast and colorectal cancer, but also depression and anxiety, Alzheimer's, dementia, osteoarthritis, back pain. So that's why it's important to recognize, diagnose, and treat obesity. So, and this is just a similar slide with a little bit more complications. So it's a big list of complications. So that's something that we need to know. And also, one important thing is obesity is closely related with cancer, with women with all these types of cancer and in men with all these types of cancer. And the mechanisms are really complex. And in order to treat this disease, we need to understand the underlying mechanisms at the cellular level for obesity. And this becomes complicated because the obesity have a brain, the physiopathology or pathophysiology of obesity have a brain component, have a fat component, but also liver and gastrointestinal system component. Because we have hormones secreted in the hypothalamus, we have hormones secreted by the fat, and hormones secreted by the gastrointestinal system. And through a coordinated interplay between these hormones, that's how obesity happens. One important thing is like pathological expansion of adipose tissue, and I'll talk a little bit more about that a little bit later. But the drugs that we are going to talk, the GLP-1, GIP drugs, are hormones that are secreted in the intestine and send a signal to the brain to tell your brain if you have satiety, if you are already full, or if you still have appetite. When an imbalance between those hormones happen, then is when people start to gain weight. It's a little bit more complex because it's many other than genetic factors, of course. Food and ambience factors is also a big. And here is just in the brain, in the hypothalamus, we have two types of hormones in a specific region of the hypothalamus. One of these, if these are activated, that the AGRP and the MPY neurons, people will have more food intake and less energy expenditure. And when these are the opposite neurons, the POMC, when these neurons are activated, is less food intake and more energy expenditure. So we really want to activate these hormones to prevent or to treat obesity. And and that's in the brain. The other important part, and that's the part that I do in my lab, that I work in my lab, is the adipose tissue. It's two types of obesity. It's people who is obese but is healthy, meaning they don't have diabetes, and that what they have is they have more fat cells, but the size of that fat cells is normal. The people who have fat, like same number of fat cells but bigger, that's the people who has the most problems with problems with obesity, like problems with the heart. So here is why obesity must be treated. And this is something called hazard ratio. And if somebody is not obese and have a body mass index normal, usually most of these diseases like ischemic heart disease, stroke, diabetes, except for couple, this everything below 1 is less risk. Everything above 1 is more risk. Like for example, somebody who is obese with a body mass index above 25, but just overweight, it has 39% more risk of have myocardial infarction. And the other thing is somebody who is obese, this is somebody without obesity, and the survival, you can see is almost normal. And this is somebody who has obesity and complications of obesity. And you can see how the survival is much less. So that's why it's important that we need to recognize, diagnose, and treat obesity. And this is the other thing. All in these are diseases that have more risk. And if you treat obesity, then this is people who receive strong treatment for obesity. This one that were treated for obesity, they have much less complications of obesity. So that's why it's important. What are the treatments for obesity? Lifestyle changes, that's the most difficult of everything. Pharmacological treatments and bariatric surgery. And in general, here in this particular guides, they what they try to do, and they divide in different stages where people start to have complications. The treatment should be more aggressive. And here is basically, just start always with lifestyle therapy, and it's just advice to lose weight, advice from a dietitian. These very famous like Weight Watchers, structured programs, or more complex programs driven by a physician. The pharmacotherapy, that until recently we only have these few medicines in black that basically, especially phentermine, these act at the central nervous. But the problem with these drugs is people develop tolerance, meaning that with the time, they don't exert the same effect, and they are no longer effective to treat obesity. Orlistat is another, what it does is avoids the absorption of fat at the intestinal level. But with this drug, people lose between 3 to 5% of the weight. And to see a real benefit of losing weight, it needs to be about 10% of weight loss. So then recently, we have these GLP-1, GIP drugs, and I'll explain what this means. And when people is really what we call morbid obesity, people who have a body mass index about 40, sometimes is preferred bariatric interventions, surgery, that basically is right now the more effective, but also have some possible complications because these are big surgeries. Right now, diet and exercise have worked, but exercise is not only work. People doesn't lose too much weight with exercise, but it helps to have less inflammation in the fat, less fatty liver, less fat in the muscle. And right now, this is how usually your gastrointestinal system, where we have the stomach, the duodenum, and the small intestine and the large intestine. And what these surgeries are, some are much more complicated, is like, for example, in this case, they bypass the stomach so that people get full faster. But these are really more complex surgeries. In some, they totally remove a part of the stomach. You can see these two, these are the more complex surgeries. They have up to 30 or 40% weight loss, but also they have a possible serious complications. So we really need to choose. And before this, we didn't really have effective pharmacological treatment. right now, let's talk about the current pharmacological. I told you about these drugs that act in the brain. The problem with this is they develop tolerance. The weight loss is just 5%, 7%. But right now we have this GLP-1 receptor agonists. That we have mainly, these are 3 approved by the FDA, and actually these are already available here in Mexico. I think this came a little bit, this is quite busy, but basically tell us right now that tirzepatide, that's the most effective, is people can weigh almost 20%. That's very close to the surgeons. And basically, okay, GLP and GIP hormone, this means glucagon-like peptide 1 and glucagon insulinotropic peptide. These 2 are hormones that are released by the stomach to give signals to your brain that you are full, so you stop eating. So the doctors and the researchers were trying to find drugs similar to this, that were doing the same function of these hormones to treat obesity. And here we came the research. And that's why basic research is so important. What the doctors, the medical doctors do with the patient is important, but nothing of this came if we don't start from the basics. Some random guy in Arizona was studying this lizard. This is a venom lizard called Gila monster or Gila monster. I really don't know how it's pronounced. And this is a venom. And they were studying the venom. It was not related to obesity or anything, but they found a peptide that was very similar to the GLP-1 human hormone. The problem with the GLP-1 is they have a very short life. You put it, and in 5 minutes, it's out of the blood. So it was really hard to create a medicine or a medication from that. So when they found this in the Gila monster, one of the researchers, that he was not a doctor, thought, well, maybe this is going to be helpful to develop a drug to treat obesity. And that's what they, this was Exendin-4, was the first GLP-1 drug that was created or was discovered. I think this is 1996 or something. So that's why you won't imagine from a lizard, the venom of a lizard will, the most effective pharmacological drugs were developed. And what is the mechanism of actions? And actually, this is what I really like. The GLP-1, when we give these drugs, what happened is they decrease appetite and increase your fullness, but they also have another actions in the pancreas, in the liver, in the muscle, in the kidneys, in the blood vessels, in the heart, and in the stomach. So it's just not affecting the stomach, but also affect in many other organs. That's why these medicines, I must say that the people from Lilly and Novo Nordisk are now millionaires. I don't know, we all should have stock from those like 10 years ago. Then once this drug was discovered, and these new drugs, what they said it was in 1995, and they sell like 700 million, even it was not that effective to weight loss. But more recently, and that was about 5 years ago, 6 years ago, the new GLP-1 drugs were out in the market. And first, before a drug goes in the market, it needs to be clinical studies in humans. Many of those studies first are done in rodent models or primates, macacos. In particular, in my case, I used mice. But when we pass to the clinical studies, first they look for weight loss, diabetes prevention, remission of complications of obesity, prevention of cardiovascular events, because stroke and heart disease are the worst and the main complication of obesity. And of course, the side effects. And here is a study. If you give somebody placebo, meaning that is something that looks exactly like the active drug, neither the doctor who is doing the study or the patient know what we call that double-blind studies. And you can see this is in the case of diabetes, this is it's called light-headed hemoglobin, that it's useful to see if diabetes is getting in control. And you can see with this semaglutide drug, have you heard about Ozempic? Well, that's semaglutide. So Ozempic is the commercial name. Semaglutide. See, here is somebody with placebo, basically no weight loss. With the lowest dose of semaglutide, that is 0.5 milligrams, we see, and this is how much they weigh, like in average, they weigh 92 kilos, and some lost almost 10 kilos. With the higher dose, they almost lose like 15 kilos. So it's really, really effective drug. This is another one. This is, have you seen, have you heard about Monjuro? Monjuro is the other one that is commercially available, that's tirzepatide. And these are comparing tirzepatide versus semaglutide. With semaglutide in green, you can see they lost, and this is a percentage of weight loss. They lose like 30%. But tirzepatide, that is much more effective. This is a dual agonist. We call dual because it's for GIP and GLP-1, and semaglutide is just for GLP. They lose almost 20%. That's similar to one of the surgeries. And also this can be used in people who's very, very obese before surgery. So they lose some weight, and then the surgery is less risk because they are less obese during the surgery. So these are the current approved GLP-1 based therapy, and these are the clinical trials. Doctors like to put these names: Amigo, Scale, Select, Pioneer. And these are the different drugs. So far, the more effective is tirzepatide, that is Monjuro, and it's used. The main use is type 2 diabetes and obesity, or obesity and type 2 diabetes. And here is basically every of these drugs in different doses. This is the change in the hemoglobin glycated. That tells you how your diabetes is controlled or not. And this is the body weight. So you can see, compare with placebo, all these drugs are highly effective. Like, for example, this is the percentage of subjects that reach about 20%, like almost 70% of the patients lose weight. Here's the more amazing thing about these drugs. These drugs right now are not approved, but are being studied, like for example, for substance abuse. People who has from nicotine, like hard drugs, heroin, or those kind of things, alcoholism is actually being very, this could be the future to results, because at the central level, so that's why are being studied. But the other amazing thing, even in people who is no obese, they help to prevent cardiovascular disease. That's the main cause of death in humans. Well, that's the sad part. What are the side effects? And it's that's very common side effects. And the main is because this make you feel full. What you are going to have is nausea and vomiting and diarrhea. The newer, like tirzepatide, the side effects are less than like the semaglutide. And up to 20% of the patient can abandon the treatment because of the side effects. And the less common, some people can have low blood glucose and other problems in the gallbladder. It's some contraindications, for example, some people with diabetes that they already have problems with the stomach. I don't give these drugs to them. It's very rare in rats. It was related to a specific type of cancer, but that was not in humans. But it still is contraindicated in people who have a very specific type of cancer that is familiar, because it's a genetic cancer that is very rare. The other part is ethical concerns, and I don't know if the commercials here that during the Super Bowl are the same or that, but I think Serena Williams, the tennis player, she advertised this drug, but she advertised not through. I mean, right now in the United States, there's many that they got an emergency approval because they start to use it, but they don't have the quality control of the main pharmacological companies. But also, like in Hollywood, people who is not obese is using these drugs when they don't need the drugs, just to look supposedly better. So concluding with this, these are very effective, durable weight loss and better visceral control. This is very important. Another problem, and this is really, really important, with these drugs, you lose fat, you lose weight, but you also lose muscle. So these drugs needs to be together with a really comprehensive exercise, so you maintain your muscle and only lose fat. And that's really important. Right now, it's another small molecules that are given together with this drug. These are in research that right now that keep your mass muscles. I think that's about basically everything about GLP. It's quite simple. I don't know if you have a question here. No questions? Yes.
Have you worked with Wegovy?
I know the studies. Wegovy, okay, because names are different. I think Wegovy here is semaglutide. Yeah, it's semaglutide. And the difference, that's what patients say. Between semaglutide is people who use semaglutide, they basically hate the food and they don't enjoy. That's the difference with Cetapide. You're Cetapide, you still enjoy the food, but without eating too much. So, and the side effects are much less with the Cetapide than with the semaglutide. So that's basically the big difference between those two side effects and that.
Which time will you say it's better to use those kind of?
Well, it's several things. Right now, most of the endocrinologists prefer to use tirzepatide. The problem sometimes is the availability, because even in the States and here sometimes could be shortage of this. And the other huge problem is the cost, because these drugs in the United States, 1 month of treatment is $1,000 if you don't have a good insurance. And right now, many insurance are not covering $1,000. Here, I think it's about 8,000 pesos per month, something like that. So not everybody can afford this. And the companies, unfortunately, they are not non-profit companies. They want to make profit, unfortunately. But that's the main problem.
I have another question.
So from this modern perspective, GLP-1s were developed to treat type 2 diabetes.
Yes.
Basically. But on the other hand, you have like more conservative treatments, like metformin and so on. So what would you say would be like biggest differences? Because I'm assuming not every treatment, it's not one size fits all.
Exactly.
For everybody.
And that's true for every problem. Like in diabetes, you go stepwise up. if you have somebody that maybe is not that obese and they have a good diet and everything, I will start with. And also you need to see socioeconomical perspective,
Yes,
unfortunately. If at this point, well, these drugs are relatively new, people think that, oh, we may have not seen all the possible side effects. Because these drugs have been in the market for 5 to 8 years. I think that's still time because exenatide Bayetta was the name, is the name. It's been in the market longer. And so far it's not like really like cancer or other side effects. I think that's why we endocrinologists think that these are like great future for the treatment. And especially not only because the treatment of obesity, because the prevention of cardiovascular disease, because that's what finally kills you. So the cardiovascular disease. And these really are receptors for these hormones in the heart. So these act in the heart, and the heart actually is a strong. It's even some studies that people who is not obese but had history of myocardial infarction, and they are studying if these people will live longer, even if they are not obese. The results are still not out, but that could be a really future.
Thank you.
And I'm just going to show you a couple of things that I do in the lab. I basically work, and we sometimes research become very specific things. I study just a protein, a single protein. That's what I do. I have done for 16 years, the same protein. And it's a little bit related to GLP-1, I'll tell you why. Somebody have heard about brown adipose tissue? Do you know what is brown adipose tissue? We have different types of fat. In the human, we have white fat. We call it, that's the fat that we always know, and that's the fat that accumulates here. It accumulates here, and we have something beige fat, and I'll tell you why. And we have something called brown fat. You know everybody that we have hibernating animals, right? Birds and many others. Those animals have lots of brown fat. The work of brown fat is generate heat. Birds like hibernate, I mean, they eat a lot during the summer, and then during the winter they sleep most of the time, and they need to maintain the heat. And what they do is they activate the brown fat. If you have a bird, they have tons of brown fat to maintain the heat. In humans, when we are born, when you are a baby, you have a little bit of brown fat. But when we grow up, that fat almost disappears. However, and this is what I was telling you, the two shades of fat, that's the white fat, that is mainly fat, that all the white is fat. And then we have brown adipocytes, that's basically the brown fat. And the main thing is they have a lot of mitochondria. And this mitochondria is different to every other mitochondria, like it's different from the mitochondria in the heart. These mitochondria have a protein called UCP1, coupled protein 1. And what it does, instead of use ATP to produce energy, bypass the ATP to produce heat. It's uncoupled the mitochondria from the ATP produced heat. So recently, and this is quite recently, it was recognized, and these three were published, this is 2009. Actually, that's the year that I started to study this, now in humans, that they started to study some humans, and they found some existent depots of brown fat. So they thought, well, this could be a really cool gold tissue. If we activate brown fat in adult humans, they can lose weight because because they will be burn that fat to produce heat. So, and how you do that? You put people in the cold, and they will activate the fat. And this is what it shows. This is like, for example, this is the most obvious. This is a particular, they use isotopes to label the brown fat in the human. And this is somebody who is in the thermoneutral condition that in the human is about 24 Celsius degrees. And they put in the cold and they do before and after. And all these that activates is brown fat. So this fat can be really helpful to treat obesity. So that's basically what it is. I studied this family of proteins, and in particular this protein called perilipin 5. This perilipin 5 is highly expressed and is in the human too. I studied in the mice, and it's in the human too. It's highly expressed in oxidative tissues, and one of the highest is brown adipose tissue in mice and humans. So when I started the lab, 2009, I create 2 mice models. One that overexpressed that protein, and this is genetically engineered mice. One that overexpressed this protein in the brown adipose tissue, and one that knockouts in the brown adipose tissue. And then I started to study these mice. And the thing is, we cannot do this in humans, we do it in mice. And what I see is this is nobody's electron microscopy, right? And I think this is 5,000 X. I'm looking 5,000 times closer in the cells. And what you can see here is the mitochondria. This is the control mice that is normal, that it does not have more of this protein. And when you have the mice at 23, you see this is the crystal, the mitochondria, there's the energy is produced. And when you put it in cold, you have more of this crystal. When I overexpress this protein, now we have more crystal, but even at 23 degrees. So if I overexpress this protein, these mice, if I have put the mice in the cold, but it was not in the cold. So this other one is the opposite. I eliminate this protein from the mice, and what happens is you can see how the mitochondria is sick at 6 degrees, meaning that this protein is really important to maintain the mitochondria in the brown, because these are brown adipose cells in the mice, and we already have some human data, but that's too new. And this actually, do you know what is this? This is, I love to do these things. It looks like art, but it's not art. This is called immunofluorescence. What I do is I isolate cells and I culture the cells, and then using primary antibodies against my protein of interest, I label the cells, and then I put a fluorophore. Then I use a special microscope called fluorescent microscope and took pictures. So I can see blue here is the fat, red is the protein that is surrounded, and green is the mitochondria. So I label these 3 things. And then I do all kind of treatment in the cells and see how my protein behaves. In this case, you can see some yellow here, meaning that my protein is together in the mitochondria. So, and it's only in the mitochondria when I treat the cells with something similar to the core. So this protein activates the brown fat during cold. Basically, that's what it is. And that's how I have millions of these things. And that's all. That's it.
If you have any questions, remember you can ask the questions in English, or if you feel more comfortable in Spanish, you're also welcome. So who has any question or pregunta?
What is like the average of the percent of the glucose of the obesity?
Like, for example, if you have somebody with diabetes, and what it does in the clinical studies, we don't measure a single, we measure glycated hemoglobin. That's an average of glucose. And let's say people, and this is a little bit rough numbers, but it's, let's say they are either 200 milligrams per deciliter, and they can be almost normally 123. And that's, I took that numbers from the AH1B number, the replicated hemoglobin. Yes.
Has there been like effects on the brown fat from using the GLP?
Yeah, so I forget about that. Not the GLP-1. It's not GLP-1 receptors in the brown fat, but the GIP, that's the other hormone, is expressed in fat. And it's already some studies that this drug, especially if it's certified, we are seeing in some human, but not me, but other people have seen they increase the activity of the brown fat. So that may be an additional mechanism of action. I didn't put it there because it's contradictory results and more experiments needs to be done. But that's the reason. Actually, one thing that I'm doing is that I'm going to do is measure if the protein that I study when I overexpress in the mice increase GIP receptors in the brain. But yeah, that's very important, very good question.
Otra pregunta, ¿alguien?
I want to leave students, I don't have questions, but I think you should go first.
So is this a good treatment for people with type 1 diabetes who has obesity or not really? And how does that affect the basal insulin intake?
Yes, another good question. Like many people, I had type 1 diabetes. I know when I was 12 years old. Probably that's why I became a doctor. But I also have a father with type 2 diabetes. So actually, now my endocrinologist said I have double diabetes, and I just, oh, come on. But I gained weight, and then it's been using people with type 1 diabetes right now that has that with the time develop overweight obesity, and it has shown like promises. It's not yet approved for the use in type 1 diabetes, but is showing promising results, especially because sometimes insulin, people who have type 1 diabetes have to inject insulin, and that make you hungry. So this can be really useful for people who have those kind of things. The studies are being done in people with type 1 diabetes and GLP-1. Obese and obese, but the results are still not.
I want to say that I don't think you mentioned the treatment like affect the muscular tissues, and if it does, how is it?
Yes, what happens with this is you lose fat, but you also lose muscle mass. So right now the only thing that people that uses these drugs is exercise. So to keep your muscle mass, and not only aerobic exercise, you have to do weightlifting to keep your muscle mass. Because if you use these drugs, you will lose weight. Basically, people will lose, and people will feel tired because they lose a lot of muscle. So it's important that when doctors prescribe this medication, they prescribe, it needs to be five times a week, 1 hour, 30 minutes, at least 30 minutes, and not become 30 minutes weighted.
Can GLP-1 be used to treat other things?
Yeah, the main thing is substance abuse disorder. They are using for people who smoke, for people who use like hard drugs like heroin and those kind of things. And the reason is because the same neurons that POMC and the other neurons these are called hedonic. Hedonic is the hedonic system. Like when people use cocaine and those kind of things, that the system that they activate. So if you block that system, people start to use. And that was actually discovered by accident, because the people who start to use this for diabetes or obesity start to say, oh, I don't want to, I just to have 3 beers per day and now I don't want to have any more beers. So the doctors, the researchers say, oh, this may be another use for these drugs. And that right now is not approved for that yet, but it's many clinical studies going on.
I asked because my doctor prescribed me Wegovy for POS.
Oh, that's another. I think it's actually one of the uses already approved. The other thing is obstructive sleep apnea. The people who snore, that's POC and SARS, let's say sleep apnea are the two diseases that are approved by the FDA for the use. Yes.
And for the case of those like alternative uses, does it also have to come with an obesity problem or?
No, not necessarily, especially the substance abuse is being done in people that is not obese.
And aren't they like at risk of like?
The studies haven't been published, but I think the doses that they are using are lower than the uses that are for obesity. I'm not sure about that, so I may be lying, but I think the doses are lower, but of course they will lose some weight, so.
I have a question about one of the earlier things that you mentioned. You said that you can have fats, but in different ways. You can have a lot of fat cells that are tiny, or you can have, if you will, less fat cells that are huge, right?
Yes.
What's the difference? Like, what determines that you get a lot of the small ones or the big ones?
Basically are genetic factors. And I don't know if you have here, I kind of don't like too much that terms, but people defines like the apple shape or the pear shape obesity. The apple shape is people who is, they have legs, everything obese, and the other is central obesity, is around the waist. And usually what we see, the people who is obese, like arms and everything, they have many fat cells, but smaller. And the people with central obesity is big, and then we call that hypertrophy. And at molecular weight, what we see is the people who have bigger fat cells, they have an inflammation of the fat. And the people who have less, they don't have inflammation. And what we do is we measure inflammation markers in the fat. We took fat tissue and stain it, and then we measure inflammation markers. And however, people who is apple shaped still can have like especially problems with the joints, like arthritis or all those kind of things. So it's still good to lose weight. So. But metabolically, they don't have diabetes or heart disease, all those kind of things. Yes.
What can you do what are the factors that can increase the brown fat in adults? Because I look and I see that normally the boys have more brown fat than adults.
I think it's an evolutionary thing, because, you know, when long time ago we were really naked and we didn't have clothes and everything. With the modern life, now you have kids and you use clothes. So evolutionary that was lost. We don't need like the birds to keep generating heat. And that's why in the human that disappeared. It's an evolutionary thing. So, however, genetically, we some people who have more brown fat as an adult than other people. So that could be also genetic factors or epigenetic factors that I don't think they have been discovered yet. Another question?
So, this is related to the topic of the GLP-1. Recently, I've been seeing this like advertisements in social media, and it's all kind of fishy, right? But they're saying things like, "Oh, you know, for people that want to do that but don't want to do like the injections and they sell you supposedly does that make any sense?
It's some oral medications, but the problem is those are not as effective as the injected medications. And the reason is injected is because when you use orally, the acid destroy the drug. So, however, Rybelsus, have you heard? Rybelsus is other one that's orally. The problem is it needs to be taken 1 hour before any meal. If you don't take it with the meal, and the effectivity is much less. My bet is that the people who is developing most, especially the two main companies, Lilly and Novo, are trying to develop these drugs that are orally. Right now, what is orally, it's not as effective as the injectables. One advantage is just once a week injection, and I think they are not doing once a month injection too. But yeah, this kind of drugs was like, for people who treat and study obesity, is kind of the holy grail. It's been really surprising. And I really hope that companies start to lower the price, because this is something that everybody must be able to access if they need it.
A lot of people say that once you start a GLP-1, it's like a lifelong commitment, right?
That's true. As long as, that's another really good question that I didn't mention. When you stop the GLP-1, you will gain weight slowly, and probably you will come back. One thing that happens is you can just, you reach a dose, high dose, you reach your goal, your weight goal, and then you can lower the dose. But yes, it's a like commitment. And that's something I went to the last Obesity Society meeting, and they are trying to find something that you don't need to use this drug. So far, you need to keep through. It's a life commitment.
Well, in a sense, I mean, if you have a chronic disease,
Exactly,
it's for life, right?
Exactly.
It's like if you have high blood pressure.
Exactly.
Life.
And that's why I really expect these drugs become more available for
like a statin.
Yeah, like a statin. Oh, by the way, University of Western, where I am work, have $10 prices, but two of the more famous were the guys, is Goldstein and Brown, that were the guys that because of them the statins were discovered, and the statins have saved millions of lives. So.
Question. And one of the first things in the US map down where people you show that there are more young people in the southern part of the states with obesity than in the northern. Is there any explanation for that? Like
yes.
Weather or
more than that, ethnicity. Black and Latinos, unfortunately. But white people too, but Black and Latinos, we have genetically, we are more propense. So if you see it in South states like Carolina, Tennessee, all those, well, Texas is a lot of Hispanics. In Texas, 40% of the population is Hispanic. So that's one. And all the other things, probably the diet. The diet could be quite different in South as well. Diet is bad in all the states. But I think diet, but ethnicity is a big problem.
Because in the older people, then it feels like using the whole country. It's like younger people, they take a lot of their weight, or it's because of their metabolism.
And when
they are all there, it's almost.
It's the age. In that case, it's the older people.
And another like super, I know that with metformin, they have seen that when patients are taking it and they have to undergo chemotherapy, they see a much more higher effectiveness. So is there like something? Like
Yeah, that's it probably has to be, is this signal protein called AMPK? I don't know exactly all the answer, but if you Google AMPK and metformin, and cancer or affect, cancer treatment effectivity, it probably has to be, because one of the mechanisms of action of metformin is through AMPK. So if you look AMPK and metformin, it's probably related to the activation of AMPK by metformin. But that's what I read, and I don't know more in depth.
But is there like something?
And it could be also obesity. I mean, somebody who is obese and requires surgery or a treatment, cancer treatment, chemotherapy, usually they have more complications when they get this. So.
Well, I think could
Yeah.
be for GLP-1.
Exactly, yeah.
Another question, after any time, if people think that probably you regulate the processed food, because actually the processed food is one of the main causes of obesity, but is it going to be like regulated or no?
The problem is for macroeconomic companies, they don't, I mean, the truth is, well, it's many factors, genetical factors and all this, but processing not just for obesity, but for heart disease and for cancer are really, I think, and I don't know the statistics, but, I think the processed foods the consumption is much more higher in the States than here in Mexico, but I don't know if it's a difference.
So I was looking at, you just mentioned that saying that before the food explosion, actually obesity in the US was much lower than it is today. And it is not the only factor, but it can be one of the factors that probably is trigger obesity.
Actually, it's something very interesting that I don't remember if I read it or I hear an interview on NPR. When the NAFTA, the TLC here in Mexico, it was in the 80s, right? Was approved before you didn't find Coke or we didn't have McDonald's. And we didn't have all those kind of things. Obesity exploded in Mexico, and it's a professor in, I think it's Northwestern University in Illinois, that studied this. Obesity in Mexico exploded after the NAFTA, the TLC, when we started to have all. I remember I was in high school in the 90s, early 90s, when the first McDonald's was appeared. And that's when the obesity exploded.
That the new generations have no idea because
Yes.
when we were younger, actually the solutions we have to get them legally.
Yes,
Yes, because you cannot find them in stores.
Yes.
You had a dealer for cereal. Really?
You have a friend that got to McAllen or Laredo for shopping. Oh, bring me some Snickers, right?
Yes.
But that's the other part.
That's true. And it was like a status thing. So if you had, I remember like the rich girl had lunch.
Oh, yes, exactly.
We have all those things, and there is another one.
Yes.
Do you be beneficial to have better erotism?
I think that I don't think it's a combination so much. I think it's hypothyroidism is well figured, it is similarly effective. So if it's hypothyroidism that's uncontrolled, it maybe has some difference. But I don't think the two diseases intersect because of mechanism of disease. So I think the story will be affected.
Okay, no more questions? Okay, thank you very much for coming. We can give a round of applause to our guests. So remember, today we close with the movie. The movie is Lorenzo's Oil, and it's based on a true story. It's about a electrolytic dystrophy, which is a degenerative disease, a neurological. So I invite you to come and see the movie. It's going to be commented by another doctor, but it's going to be at 5. Not sure if we are getting full. Okay, guys, thank you.
Muchísimas gracias. No, excelente. De los minutos. Cuando quieras, y ahora tienes casa también, cuando quieras te puedes quedar.
Gracias.
Buenas tardes.
Sí, tenemos cierto. No, pero no, es que me dice que mañana se va a Ciudad de México y tal, le digo que no vengan los estudiantes, que se va a regresar, y le digo que cuando quiera empezar.
No, mi familia está en el centro.
¿Te quieres quedar? Pero pues ustedes están familiar, pues que mejor.
También quería conocerlos. ¿Me quieren? Dinero, ¿verdad?
Tienes que dar de 11 a 1, o sea, no solo de 11 a 1 van a estar poniendo los sensores, que es una hora antes de no tienes que.
A ver, ahora quién es estos chiquillos. Te animan a ir.
Bueno, nada más no
Ahora sí hablan. Pero no cago en la
se paga largo, así que se va a ir.
Se va a pagar la diferencia.
Pero no es tu abuelita. Es que vea que sí.
Sí, digo. No tienen que invitarme, ¿no?
¿Vas a seguir tu gordo?
Muchas gracias, yo me retiro. Claro que sí. Sí,
Right, the ones that.
muchos que no sabemos. En esa parte no estoy muy segura.
Pero necesitamos la lista de las personas que. Sí, porque no vaya a ser que lleguen de yo estoy en la lista y después es que se llegaron al estado, no sé.
Bueno, son los de, bueno,
Porque es no.
es que hay que ver cuántos hay. Pero recuerda que la preferencia es fácil. Entonces, si ya estamos felices aquí, pero si hay más
Porque entonces que los profesores los profes sea no, pero para ponerse a pensar.
a ver, indícame bien, tengo que mandar un mensaje.
Van a estar poniendo los sensores de 11 a 1.
De 11 a 1 fuera de 11.
Sí, o sea,
¿A qué hora es la
doctora?
En la
Pues me dijo que a las 11 o antes.
ok, entonces yo mando un mensaje diciendo que aparte de 11 a 1 van a estar afuera por los monitores.
Sí, y que si es muy necesario que lleguen antes de